Fatigue is one of the common symptom in the OPD, and sometimes it becomes very difficult for the physician to diagnose the cause and how to manage fatigue. In this video, we'll discuss step by step what are the causes of fatigue, how to approach and how to manage and treat such cases. What will be the role of very popular drug like coenzyme Q10 or antidepressants. First is the definition. Fatigue is difficulty in initiating or maintaining a voluntarily mental or physical activity. So fatigue can be a mental, that is a central fatigue, as well as the physical fatigue. So both the components are present here. Causes include, the most important cause is psychiatric diseases like depression and anxiety. While more than 75% of the patient with unexplained chronic fatigue have some sort of depression or anxiety element. So in the OPD, we will first ask about these history. Second is the neurological disorders like multiple sclerosis. So during the course of multiple sclerosis, 90% of the patients develop fatigue. Now what exactly is the reason for fatigue here? So it has been seen that any sort of chronic inflammation or any sort of chronic disease, interleukin 1, interleukin 6 or TNF alpha. So these agents they can cross the blood-brain barrier and they disturb the neurons or they cause the neuronal dysfunction, and this will lead to the fatigue. While the other chronic disorders, so if we will see the cause here, the cause here is the presence of TNF alpha. So TNF alpha is the main cytokine which is responsible for TNF alpha. It crosses the blood-brain barrier and that causes the central fatigue. Now Parkinson disease. In the Parkinson disease, there is a decrease in the dopamine levels, and dopamine is responsible for the proper neuronal function. So and it will lead to the fatigue. Amyotrophic lateral sclerosis, here the cause of the fatigue is usually peripheral, like motor neurons are affected and they will lead to a decrease muscle power. Post-stroke, so again in the post-stroke neuronal dysfunction occur, and neuronal dysfunction is a central type of fatigue. Now this is important, migraine. In some migraine, episodic fatigue also occur. Again it is a central fatigue. Endocrine disorders. Endocrine disorder, most important is the hypothyroidism. In the hypothyroidism, what happens ki there is a decrease oxygen utilization by the tissues, by the cells, because the function of the thyroid hormone is for the oxygen uptake by the cells. So there will be a decreased oxygen uptake by the cells. While in the hyperthyroidism, the main reason is the body metabolism is increased, the demand is not met accordingly, so patient have fatigue. Hypoglycemia, again this is because of the low glucose, so it can be central as well as the peripheral both, because of the decreased glucose in the brain as well as in the skeletal muscles. Hyperglycemia is a cause of usually the peripheral fatigue. And type 1 diabetes, even when the sugars are under control, even then type 1 diabetes has been associated with fatigue. Addison's disease, so in the Addison's disease, mainly the cause is low cortisol, or you can say low steroid levels in the body, and as well as there is a low blood pressure. So these leads to the peripheral type of the fatigue, like muscles, the blood flow is reduced. Low vitamin D level has been associated with fatigue. Infections, the chronic infections like tuberculosis, HIV, endocarditis, chronic hepatitis, and here again the fatigue is related to the cytokines, like the cytokine which is released is the TNF alpha, and that is the main culprit which is leading to the neuronal dysfunction. So it causes neuron dysfunctions. So you must have seen in patients, especially the chronic disease patients, they complained of these tiredness all the time, weakness all the time, lack in initiating any movements. Now the drugs. Drugs have a direct effect like antidepressants, antipsychotic agents, anti-seizure agents, and as well as beta blocker. So out of this, beta blocker is a commonly used drug. So always take the proper history from the patient whether patient is taking these drugs, and beta blocker is one of the antihypertensive drug which is commonly used. So this is one of the culprit agent which can lead to the fatigue. Multiple mechanisms are there ki why beta blocker leads to fatigue. Maybe because of the decreased blood supply to the cells can be one of the cause. The oxygen delivery is less. Hematological disorders, obviously anemia, because in the anemia there is low hemoglobin, and low hemoglobin means less oxygen carrying capacity of the blood. So oxygen carrying capacity is less, so there will be a decrease oxygen to the tissues. And whenever there is a oxygen delivery decrease to the tissues, there is always a fatigue. uh, Even low serum ferritin level, now this is very important, low serum ferritin level in the absence of anemia cause the fatigue that is reversible with iron replacement. So sometime you must have seen the patient ki patient says ki doctor sahab tiredness rehti hai, thakawat rehti hai, and when you check the hemoglobin is okay, or maybe a borderline low level, but when you check for the ferritin level, it is low, so that patient will need iron. So always make it a point, if patient complaining of these thakawat, weakness, tiredness with a low hemoglobin, just check for the ferritin level, of course after ruling out other causes. Malignancy, hematological malignancy, solid organ tissue, and disseminated malignancy, they will cause fatigue. Again, this is because of the multiple factors. Catabolic state, malignancy is a catabolic state, and catabolic state means ki there will be a muscle breakdown, protein breakdown, and they will lead to similar symptoms. Autoimmune disease like SLE, polymyalgia rheumatica, rheumatoid arthritis, again these are related to chronic inflammation. As we have discussed earlier ki chronic inflammation leads to these symptoms. Pregnancy by itself is a cause. Multiple reasons, like there can be a low hemoglobin in pregnancy, and there can be a sort of UTI, which recurrent UTIs in pregnancy, which can lead to fatigue. So multiple reasons. Chronic systemic diseases like COPD, of course this is because of the hypoxia, that patient will have fatigue. CHF, again because of decreased oxygen due to decreased cardiac output. So low cardiac output means ki less blood is flowing to the tissues, so less oxygen to the tissues will be there. And in both the chronic liver disease and chronic renal failure, the implication is because of the toxins, hepatic toxins and uremic toxins. The property of these toxins is they cause neuron dysfunction, and patient will have a central fatigue in these condition. And of course in the chronic renal failure, there is low erythropoietin, low hemoglobin is also there, so that can also contribute. Sleep disorders like obstructive sleep apnea, because of the decreased oxygenation, and due to disturbed sleep. Remember, disturbed sleep is one of the cause of the fatigue, because patient does not get rest, muscles does not get rest. Now in summary, if we revise what are the causes of the fatigue, so make a point, whenever patient comes to you, take these histories from the patient. Do not go randomly, because if you go randomly, you will not be able to come to a conclusion. So the most important is ask for the psychiatric illness, ask for depression, anxiety. Even if you start with this word कि आपको कोई stress तो नहीं है, कोई tension तो नहीं है जो नई नई हुई हो अभी, तो immediately you will see there will be tears in the eyes of the patient. So that then you will evaluate further, so it will be most likely a psychiatric disorder. Then ask for the neurological diseases and check for the motor power, check for the reflexes, so that will give you a conclusion that some neurological disorder is there. It can be drug, so always take the history of drug intake like antidepressants or anti psychotic drugs or beta blocker commonly. It can be anemia, check for the pallor, and sometime when you check for the pallor, you will determine that low hemoglobin is the reason. Don't go for complicated investigations. Infection, ask about the history of fever, night sweats, then check for the lymphadenopathy, and check for the lungs, whether there is any crepitations or any sort of chronic disease like tuberculosis. Splenomegaly will be seen in infective endocarditis or chronic disorders. Pregnancy, that is obvious, in a reproductive age group, go for the UPD test. Endocrine disorders like hypothyroidism, hyperthyroidism, take the history appropriately. Like hypothyroidism, patient will have puffiness, constipation. In hyperthyroidism, patient will have eyes which bulge out, tremors of the hand, heat intolerance will be there. Sleep disorders, ask for the snoring from the partner, ki whether patient is snoring, obstructive sleep apnea is there. Then systemic disease, ask for the history of COPD, CHF, chronic liver disease, chronic renal failure. Autoimmune disease, ask for joint pains, skin rashes. Malignancy, this will be slightly complicated in malignancy. There can be a pallor in the malignancy, hepatosplenomegaly can be there, and in the CBC, metamelocytes or blast cells can be seen in the malignancy. But sometimes it becomes very tough to diagnose the malignancy in the initial visit. Now come to step by step approach. So number one thing is, when the patient is telling you कि डॉक्टर साहब थकावट होती है, तो you should know what exactly is that थकावट, what exactly is that fatigue. So it should be distinguished from these important conditions. Number one, whether there is a muscle weakness. So in the muscle weakness, what you should do, you should check the motor power. Make it a point in the routine OPD ki motor power you have to check ki it is a true muscle weakness. Then excessive sleepiness. So ask the history of insomnia, and importantly ask the history of snoring. Ki patient have sleepiness during the daytime, so excessive sleepiness during the daytime, so it could be obstructive sleep apnea. Third thing that you have to check, ask the history ki patient has dyspnea on exertion, whether it is a breathlessness or thakavat. These are two different things. So breathlessness is ki patient will say ki after taking say few steps, patient have difficulty in breathing, so that is known as dyspnea on exertion. So just ask ki how far the patient can walk, कि पेशेंट पहले क्या 100 स्टेप पे ब्रेथलेसनेस होती थी उसको, या क्लाइंबिंग वन फ्लाइट ऑफ द स्टेयर्स पहले कहता था कि यस वन फ्लाइट ऑफ स्टेयर्स कंफर्टेबली पेशेंट कैन डू, बट नाउ पेशेंट इज फीलिंग ब्रेथलेसनेस. सो दिस इज वेरी इंपॉर्टेंट टू डिफरेंशिएट फ्रॉम डिस्निया ऑन एक्सर्शन. नाउ लॉस ऑफ मोटिवेशन. तो लॉस ऑफ मोटिवेशन इज ड्यू टू सम साइकेट्रिक डिसऑर्डर्स, कि पेशेंट की जो हॉबीज थी, जो वो करता था, क्या पेशेंट हैज स्टॉप्ड दोज हॉबीज, पार्टिसिपेशन इन द हॉबीज is there or not. So these are the four things that you should distinguish. First is the muscle power, second is excessive sleepiness, third is dyspnea on exertion, and fourth is loss of motivation, because they have different etiologies. Now these are the lines from the latest edition of the Harrison, which says that unfortunately when you are evaluating a patient of unexplained chronic fatigue, only 2% of the cases are diagnosed with general physical examination. So when you do general physical examination, check up the patient, only 2% patients it will be positive. While when you evaluate a neuropsychiatric and mental status, detailed neuropsychiatric and mental status, 75 to 80% patient will be diagnosed. So you can see the importance of these neuropsychiatric and mental status disorder. They have to be done in the OPD. 75 to 80% patient will be diagnosed. So step 1, always a detailed mental status evaluation will be done, and there are some paper, we can say scales or sheets. You can just tick mark those points on the sheet, and they are easily available. They are easily available online. So this is the most important step, detailed neuropsychiatric and mental status. Social history, like if there is any life stressors, patient has lost the job, or there is some family arguments, work hours, ki whether patient has long work hours, there is some sort of family violence, sleep habits and sleep hygiene, that should also be asked in the initial evaluation कि क्या patient पूरी जो है वो sleep hours उसके complete होते हैं, 7 to 8 hours की sleep है, और patient is waking up late in the night और जल्दी उठना पड़ता है उसको, तो these should be assessed. So, in this, the psychiatric evaluation is important here, and step number 2, drug history should be taken. Drug history is temporal relationship is very important कि जब patient ने start किया drug उसके बाद ही हुआ या उससे पहले था. Because the thing is कि suppose patient has depression, उससे fatigue था, patient will be started on antidepressants. तो you will ask कि वो पहले से fatigue था और it is after the drugs, because antidepressants can also cause fatigue. सो जो चीज़ हम ट्रीटमेंट के लिए दे रहे हैं दैट कैन ऑल्सो कॉज फटीग. एल्कोहल इंटेक इज इंपॉर्टेंट बिकॉज दिस इज वन ऑफ द रीजन फॉर फटीग. सो यहाँ पर हमने न्यूरोलॉजिकल इवेल्युएशन कर लिया, ड्रग्स कर लिए, साइकेट्रिक डिसऑर्डर्स वी हैव डन. नाउ स्टेप नंबर 3, वी हैव टू इवेल्युएट द कॉमन कॉजेज. So the common causes on physical examination can be done, like for example causes can be physical examination where you can check for the pallor. For anemia, you can check for the icterus. For chronic liver disease, you can check for lymphadenopathy, hepatosplenomegaly, for chronic infections, and this is the baseline test to be done. First you have to rule out the drug history, neuropsychiatric problems, and then write these investigations. These investigations mandatory are CBC again for low hemoglobin, and in the peripheral smear some other cells or differential counts are suggesting leukemias. Blood glucose level, because high blood glucose level or low blood glucose level are associated with these symptoms. KFT, kidney function test, liver function test to rule out chronic kidney disease or chronic liver failure. TSH is must, important, mandatory, and calcium. It has been seen that high calcium is associated with fatigue because high calcium causes a dehydration, और डिहाइड्रेशन से देयर इज अ फटीग. वाई डिहाइड्रेशन? क्योंकि हाई कैल्शियम लीड्स टू वॉमिटिंग, दैट इज अ सिम्टम ऑफ हाई कैल्शियम. इट कॉज पॉलीयूरिया, पेशेंट कई बार आपको नहीं बताएगा पॉलीयूरिया. इट कॉज डायबिटीज इंसिपिडस, नेफ्रोजेनिक डायबिटीज इंसिपिडस. सो हाई कैल्शियम इज वन ऑफ द इलेक्ट्रोलाइट जो आपको चेक करवाना है. तो दिस इज द बेसलाइन टेस्ट टू बी डन. Now ECG should be done if there is a heart rate less than 60, because bradycardia means ki if there is a bradycardia, so this will lead to overall decreased cardiac output, and decreased cardiac output means ki muscles pe oxygen flow is less. Now UPT, that will be patient to patient ki whether patient is in a childbearing age and patient is not using any contraceptive devices, so in that condition you can go for the urine pregnancy test. Now, so we have evaluated psychiatric, neurological, drug-induced infections. We have seen anemia. We have seen pregnancy. We have seen some of the endocrine disorders. We have seen here. So these disorders are important: anemia, diabetes, hypothyroidism, chronic kidney disease, chronic liver failure, pregnancy, and infections. So these are some common. यूजली क्या होता है कि इन्हीं स्टेप्स पे यू विल बी एबल टू आइडेंटिफाई द कॉज ऑफ द फटीग, एंड ऑफ कोर्स ब्रेडियर्मिया एंड हाई कैल्शियम. नाउ स्टेप नंबर 4, दैट इज नॉट सो कॉमन. नॉट सो कॉमन मीन्स कि मेलिग्नेंसी इज सच अ ट्रिकी डायग्नोसिस इन द रूटीन ओपीडी कि समटाइम इट इज मिस्ड or sometime it is over, we do over testing to diagnose the malignancy. So this is a problem for the patient as well as for the doctors. So in the history we ask the patient for history of joint pain and skin rashes, that is mainly for the autoimmune diseases. Lymphadenopathy, again that will give a clue towards the malignancies. Generalized painless lymphadenopathy. Now this is important, generalized painless lymphadenopathy, that will be suggestive of the malignancy. While skin pigmentation, vitiligo, postural hypotension, low sodium, high potassium, they are all suggestive of endocrine disorder. Not so common, but Addison's disease they will be suggestive of. So these are the in the step number 4. And CBC leukocyte and blast cells will be seen, and they will be suggestive of the leukemias. Now comes the management. So the management of idiopathic chronic fatigue, because whatever is the cause we have identified, like if it is anemia, so supplement with iron, simple. If it is hypercalcemia, treat hypercalcemia, identify the cause of the hypercalcemia by doing the PTH test. Hypothyroidism, give levothyroxine. So any cause which you are able to identify, treat accordingly. But if there is idiopathic chronic fatigue, lifestyle changes are important. Number one is a sleep hygiene, number one. So if sleep hygiene is disturbed, regular sleep schedule should be there. Ask the patient to avoid screen time and avoid coffee intake afternoon. Other lifestyle changes will be, this is now important, graded exercise therapy. One of the most ignored part in the management of chronic fatigue, graded exercise therapy means gradually patient will be asked to increase the exercise capacity. How it is done? Let's see. One protocol, every 1 to 2 weeks, increase the activity by 10 to 20%. Like in first week, ask the patient to go for a 10 minutes of walk, 10 minutes of walk. In the next week, you ask the patient to increase it by 20%. So increase the walk by 20% of minutes. So increase the duration first. So if the patient was going for the walk 10 minutes in first week, ask for 12 minutes of walk in the next week, or 15 minutes of walk in the next week. So increase the duration first of whatever physical activity patient is advised. Then increase the intensity, like first slow walk, then increase the duration. So gradually increase the duration to 30 minutes, a slow walk. Then after that you ask the patient to increase the pace, that is increase the intensity. That is the meaning of graded exercise. Now the cognitive behavior therapy, that is one of the method which has shown to improve the fatigue. Not the drugs, but cognitive behavior therapy, that is done by psychiatrists and psychologists, in which the steps which are done is first identify the negative thought, because patient कहता है कि उसको negative thoughts आ जाते हैं, and due to the negative thoughts patient को there is no motivation for walk. So there is a vicious cycle which is created. So first identify the negative thoughts. Second, रिप्लेस द नेगेटिव थिंकिंग विद रियलिस्टिक थॉट्स. तो रिप्लेस करना है कि अगर पेशेंट को हम बताएं कि इफ़ पेशेंट विल गो टू द वॉक, तो उसका मेडिकल प्रोफाइल इंप्रूव होगा और इंडीड वो देखने में भी अच्छा लगेगा, फिजिकली फिट रहेगा. तो दैट विल बी अ किक फॉर द पेशेंट फॉर पॉजिटिव रियलिस्टिक थॉट्स. चेंज द बिहेवियर. नॉट ओनली की थॉट पहले से चेंज करनी है टू पॉजिटिव थिंकिंग, बट ऑल्सो दैट शुड बी कन्वर्टेड इनटू एक्शंस. सो चेंज द बिहेवियर अकॉर्डिंगली. तो हियर मल्टीपल सेशंस आर नीडेड बाय द साइकोलॉजिस्ट और साइकेट्रिस्ट. नाउ कम टू द मेडिकेशन, द इंपॉर्टेंट पार्ट फॉर जनरल प्रैक्टिशनर, कि patient does not have any identifiable cause of the fatigue, still patient is symptomatic. patient बताता है बहुत दुखी है, उसने सब कुछ करके देख लिया, तो what can be done? एंटी डिप्रेसेंट्स तभी देने हैं when there are depressive symptoms, and for that you need to take the psychiatrist help. So chronic fatigue with depression, only then you will give antidepressant agents. Now this is the agent, this improve alertness and wakefulness. Intentionally I have not put the doses of this drug because it can be misused. So this is for the general practitioner, and they should take their decision. This is not for the general people. So this agent mechanism is, it increases the extracellular dopamine, particularly in the prefrontal area. Like we have said, if there is a dopamine deficiency, alertness is low. Dopamine is increased, alertness will improve. So it improves the alertness and wakefulness. Patient will feel motivated. It decreases the GABA activity. GABA activity is inhibitory. GABA पे क्या काम करता है? GABA receptors पे benzodiazepines काम करते हैं which cause sleepiness. तो it decreases that GABA. And duration is trial for 2 to 4 weeks, and then assess the benefit कि आपने continue करना है or you can stop this medication. Side effects are insomnia, headache, anxiety, or GI upsets. Now the supplements. This is one of the supplements which is very commonly used in India, coenzyme Q10, and we have seen the prescriptions from the GPs कि almost every second or third patient this coenzyme Q10 is written, but this is a costly drug. Do not misuse this drug. Coenzyme Q10 mechanism of the action is it help in regenerating, it help to regenerate the ATP energy source via oxidative phosphorylation. It also neutralizes the free radicals which are generated during the energy production. It protects the lipid protein DNA from oxidative damage. So these are the mechanism of action and so much benefit of the coenzyme Q10. Dose is 100 to 200 100 milligrams per day, and that can be used in a patient with chronic fatigue. But the benefit, according to the standard textbook, hardly any benefit is seen. But we can try patient to patient, we can take a decision for coenzyme Q10. Now B12. B12 should be given only when there is a B12 deficiency. No benefit in a normal B12 level patients. Again, iron. Iron only if the ferritin is less than 50. So this is the indication of giving, and even without anemia. This we have discussed ki patient have normal hemoglobin, still ferritin is low. In that condition we can give iron supplements, and new iron supplements you can give because the other iron supplements like the iron sulfate or other preparation, they cause gastric disturbances. But now the newer liposomal preparations of iron, they have less side effects of gastric irritation, so they can be given. And for the iron deficiency treatment, you can watch other videos on this channel, how to treat the iron deficiency. Now L-carnitine. L-carnitine 1 to 2 grams per day. Mechanism is it transport the long chain fatty acids across the mitochondrial membrane, and then fatty acids are oxidized to produce ATP. So this is actually using the fatty acids to produce the ATP, energy source. And the main role of L-carnitine is in cancer and CKD related fatigue. So this is according to the Harrison, they have mentioned that L-carnitine should be given in these two scenarios, but in other patients we can try for the L-carnitine as well. So this was about the fatigue, and if you have any questions, any doubts, or you want to share your experience about using these drugs, you can put in the comment section. Thank you.